And I've always found that composite resin has been such a useful tool to allow us to phase treatment for our patients. And the reality is that we really need to be able to do it well, or we might lose some of these cases for patients who just can't afford to do porcelain restorations. And that would be a real shame because I feel like anyone on this webinar could probably do a better job for their patients than someone down the street who hasn't had your training, regardless of what material you use. And there are a lot of situations where we need to be able to use resin and perform at the highest level, just like we do with all of our other cases. So let's talk about some of these cases, a few times where we might want to incorporate resin into our treatment options. So obviously, if we have patients come in, emergency patients with fractured teeth, that's a time that we might need to use our resin skills. A lot of younger patients, their parents just don't want them to have to cut down the tooth or remove much tooth structure to restore their teeth. So they are in that patient population where we might need to use our resin skills. We've got a lot of conservative patients. This patient to the right of our screen here, her mom is in the dental field. I'm going to show you her case in a few minutes, and wanted to do just really additive technique, didn't want to prep the teeth for porcelain veneers. So we did a full 6-unit composite resin case on her. As we mentioned earlier, some of the patients that have budgetary concerns and want to learn how to phase their treatment plan, this is a good option for them. And then finally, you remember Pete always talked to us about the Whittiam rule. And the Whittiam rule is, would I do it on me? And oftentimes I just think, when the patient comes in, what would I do if this were my tooth, if this were my daughter, if this were my sister? What kind of treatment would I want to have in my own mouth? And remember that Pete always said that the best treatment plan includes the least amount of dentistry that we can do on our patient that will give them ideal aesthetics and function. So let's look at a few examples of situations where we might need to call on our excellent skills with composite resin. So we mentioned emergency patients or patients with fractured teeth. So this is Sam, and Sam is 20 years old, and he attended the same K-8 Christian school that my girls attended. And Sam came in with several busted front teeth after a bike accident. And we didn't have time in our schedule to prep crowns, nor did I have a matrix to make provisional crowns. But even without a wax up and a matrix, I think that this case turned out beautifully. And it was an incredible service to this patient and to his family. And honestly, again, isn't this what we would have wanted if he were our son? Could he use some Invisalign on his lower teeth? Yes, probably. Drew, I think, are you on here tonight, Drew? Does he have some wear on the laterals that indicates some functional issues? Yes, he does. But because we were able to address their chief complaint with some nice work today, then we hopefully will have the chance to see them again in the future. And maybe his whole family will become regular patients. So you can see why this is a critical tool to have in our tool belt. And this is Paul, and Paul is a college student at Auburn. And I will give you 3 guesses how Paul broke his front tooth. Opening a beer bottle. And so this is a really fun case because we got to use some of the opacers that we're going to teach you how to use in the hands-on class. And we had to make the distal of number 9 a little bit shorter due to his function, but I think we can all agree that this is a very nice solution for this patient who had to drive back to Auburn for class the next day. And this is Emily. Emily's a high school student, and she is actually a patient of my husband's. My husband's also a dentist. And she came in on a Friday afternoon when he was out of the office, probably out deer hunting. And there are a couple of things that I might do differently after I saw these photos. For example, I would round that mesial embrasure a little bit more on number 8 to have it mimic number 9, because we want these kissing embrasures, the ones that are touching each other or facing each other, to be mirror images of each other. And I might roll that mesial facial line angle out a little bit more to the mesial of number 8, so that when we take a photo like this, we can get the same exact light reflection off both of those central incisors. And as we really learn to master our bonding technique, mastering this light reflection off the line angles is going to be key to creating a really natural, symmetrical looking restoration. But Emily and her mom were both incredibly happy. And this was another fun case where we got to use our opacers to mimic some of the white effects that she had in her natural teeth, as well as building in some translucent layering on her incisor there. And we're going to go through a step-by-step case in a minute for how to do an invisible class 4 composite tonight. But first, let's talk about some of these other case types where we might need our composite resin skill set. So we also talked about younger patients. This is another people in this category, teens, and, you know, sometimes due to budget, but sometimes just because we want to do the least amount of dentistry that we can do for them. And this is Taylor, and Taylor presented with peg laterals, and she's 25 years old. And in addition to the laterals, she had some functional issues. You can see on her canines on that upper photo, her pre-op photo, her canines are worn down and her central incisors are chipping. So on the left, you can see her before retracted and smile photos, and the right are her afters. And we did full bonding on her lateral incisors, and just the incisal half, maybe the incisal third, I kind of lose track of where that margin is on the centrals and the canines. And I think this just turned out to be a fabulous aesthetic result and so conservative for these patients. And now her mom has come in to have her whole smile redone. And look at the color. We brought up her color a little bit, about half a shade, but such a nice blend with the rest of her dentition. And these are her close-ups. Befores are on top and the afters are on the bottom. And there's always a couple little things I want to tweak, but this case came out really well. I love on the centrals how you just can't detect that finish line. And we didn't bond the entire tooth, remember, on the centrals. We used a matrix that we're going to show you that technique in just a minute, a matrix from the wax up, the digital wax up that we did for her to form the incisal edges. And of course, she was equilibrated. And by adding the length back to the centrals and the canines, we restored her anterior guidance. And Blake is another younger patient. He's 19 years old, and he's a sophomore at Notre Dame University. And he had this canted occlusal plane that you can see an excess gingival display, especially primarily on the left side, that he was unhappy with. So after he saw the periodontist, we decided to do what I call a mixed medium case, where we did porcelain veneers on his incisors, and then we chose to bond his canines to get centric stops and canine guidance. And we could have chosen to bond the whole case, but this was an ideal plan for Blake, and it fit perfectly into the budget that he and his family had for his case. And these are some retracted before and after photos for Blake. And I love how the margin on the bonding on number 6, for example, when you use this technique that we're going to go over in a minute, it just totally blends into the natural tooth, and you can't see where the bonding stops and where the tooth starts. And this is Blake.
I'm not sure I understand.
Siri's talking to me. And this is Blake when he went back to Notre Dame with his new smile. And I'm thinking that maybe he collected some digits once he got back to school. All right. So the next category that we're going to look at is conservative patients. And this is Haley. And Haley's mom is in the dental field, as I said earlier. And when Haley got her braces off, obviously she had some significant spaces left over because she had a Bolton discrepancy in addition to these peg laterals. And she was still in high school when we did her teeth. So her mom really wanted to do something that was very conservative. We did very little prep on Haley, less than 1/3 of a millimeter, since we were building her teeth out a little bit. And this served her well for many, many years. And this is Lisa. Lisa is a hygienist from Augusta, and she was in Invisalign when she came to see us. and just was not willing to continue with Invisalign. She wants to close the spaces between 8 and 9. And you can see that she doesn't have canine guidance on the left. She's kind of an edge to edge type occlusion here. So we have to work out her anterior guidance. And Lisa just does not want to prep her teeth for veneers. We would have to open the contact completely between number 8 and 9 if we want to close that triangle with porcelain. But with a mylar strip or a BioClear matrix that we're also going to talk about later tonight, and some diamond finishing strips, we can close this contact with very little or no reduction for her. So we're going to give Lisa both options, but she's already told us that she's more interested in doing bonding. And another situation where resin can come in handy is these bigger smile design cases where the patient has budgetary concerns and they want to phase treatment. And this is Brenda here, and Brenda's a Baylor grad, Sikkim Bears, and she lives in our neighborhood, and she has been on SSRIs for many years. And this is what happened to her dentition. And Brenda could easily be a full mouth reconstruction case because she is flat as a pancake. But we offered her the option just to build up the posterior molars in composite resin. And for 8 molars, that saved her almost $16,000 in porcelain crowns. So this is still a fabulous case. And we didn't lose the patient because we offered her a way to phase her treatment. And this is obviously a case where we're opening her VDO slightly so we can get space for the restorative material. But this allows her to treat her entire mouth, and we can replace the resins by quadrant or individually, or the truth is that some of them may not even have to be replaced. But we do this so often. I feel like probably 75% of the cases in my practice that need full arch dentistry, we treat this way. Unless they have full crowns on those posterior teeth, on those molars that need to be replaced. But even sometimes in those instances, we just microabrade the porcelain on those posterior crowns, silinate them, and place some unfilled resin, and then bond right on top of those crowns just to get a centric stop. And don't be fooled. Patients appreciate this. It builds trust, and they will refer people just like them. And with the cases that you do, I would say just think about what you would want done on yourself or on your child or on your sibling. And our goal is that you would have so much confidence after you finish our hands-on resin course that in your bonding cases that you would offer the bonding option to every patient that you have, and always be able to offer the patient both options. And in an economy like this, I think good resin skills are going to enable us to do more of the kind of dentistry that we want to do, and more of the dentistry that the patients need to restore their function and their anterior guidance. And we're going to have fewer patients walk away from sticker shock. And this case is one of my partner that teaches the resin class with me. This is Javier's case. And this is 6 maxillary composite veneers on this patient. And we're going to teach you how to do that in the course. We're going to teach you how to do 6 maxillary composite veneers in one day, 6 mandibular composite veneers in one day, and open the bite or do an additive equilibration in the posterior. We're going to do a full mouth reconstruction with resin, and you're going to leave with the confidence to be able to do it and to make it look beautiful like this. Because as Glenn DuPont always told us, we don't want to forget the little guys. We're actually going to do a whole 6-unit lower anterior case of resin veneers as well. And as, like I said, open the bite with additive equilibration. All right, so I want to move on next to our class 4 composite technique. And I know this may seem like something simple that you guys do every day, but in a recent survey of dentists, they said that the hardest thing for them to do in practice is a class 4 composite. And if you want to get your accreditation in the Academy of Cosmetic Dentistry, then you need to be able to do an invisible class 4 composite. So we're going to talk about it tonight. We're going to teach you how to do it hands-on in the resin course. And so you're gonna get a little preview with Sarah. And this is Sarah. You can see this old discolored class 4 composite that she has on number 8. And you can see it even from a full face photo here. And it's even more apparent as we move into her smile photos. But the length and the horizontal position, the incisal edges are pretty good. Maybe even a little bit on the long side, if anything. And these are the retracted photos. And she's got a little bit of wear on her anterior teeth. So my associate doctor actually did an equilibration on her, but they saved her class 4 composite for me because they knew that we were looking for some good cases for the course. So we're going to walk through Sarah's case step by step. And these are her close-up shots. So let's go through our step-by-step technique for our class 4 composite. So we're going to talk about shade selection, how to do that and when to do that. We're going to talk about isolation, which is so important and so easy the way we're going to teach you how to do it. A long bevel, the longer the better. We want to etch and bond the whole tooth, the entire tooth, even though we're just bonding a portion of the tooth. We're going to wax up our proposed results either digitally or on an analog model and fabricate a matrix using a putty or vinyl matrix right now, but we may get to a point soon where we're printing our matrices to use for our bonding techniques. We want to use liberal use of white effects if they have white effects in their natural teeth that we're going to be matching. We need a highly polishable microfill for the labial surface. This is a key in our full composite veneers as well as in our class 4 composite. We're going to talk about how we mimic the natural tooth anatomy. And then we need a really fine superior polishing system. All right, so when we talk about shade selection, we're going to look at a shade that will match the main body shade of the tooth. And we want to do this while the tooth is hydrated, and preferably before the anesthesia, because our anesthesia can change the color of the tooth slightly. And you want to select your shade in the same plane as the tooth. So just like when we take our shade photos for a single porcelain crown in the front, you want your shade tab to be in the same plane as the incisor that you're matching, because if the shade tab is closer to the camera or closer to your eye, then if it's more forward, it's going to appear lighter. And my preference is actually to take a little button of the shade of the composite material that I think I want to use and place it right on the tooth and cure it before we confirm, just to confirm that that's going to be the best shade for this composite. So we want to make a really long bevel, and we want the bevel to be long for a couple reasons. First, for color blending. The longer the bevel is, the better our shade is going to blend into the natural tooth. And we want a smooth transition onto the natural tooth. Even a longer bevel than this is good. And in addition, it's going to provide more surface area to bond to. And the more tooth that we're bonding to, the stronger our composite is going to be. The more coverage you can get, the stronger the bonding is going to be. And then we want to etch and bond the whole tooth so that any flash of composite that goes beyond the bevel won't stain. Because if you stop short with your etch or with your bonding agent and there's flash, then it can start to discolor underneath the edge of that flash of composite that goes beyond the bevel. And if we are etching unprepped tooth that's beyond the bevel of the unprepped enamel, we're going to etch that for 1 minute. And then the prepped enamel, we're going to etch for about 20 seconds. And I like to place some Gluma, the glutaraldehyde and Hema. I use Patterson's brand, which is called Huraseal, on any of the exposed dentin. and that improves our bond strength and it helps combat any sensitivity. And then we're going to place a 5th generation bonding agent on the entire tooth. And then our lingual part of the resin is packed into our matrix that we made off of our diagnostic wax up. And then we add composite, we bevel that composite up onto the labial and incisal surface of the tooth. And we're going to seat the matrix up against the tooth with firm pressure and then use a composite instrument to smooth that junction in between the matrix and the composite that we've placed on the tooth. And this portion of the tooth that's in occlusion and function is going to be built up with a microhybrid composite. And this patient did have some natural white effects that you can see in her teeth. So I've found when using opacers that the more is better, primarily because they're going to be underneath our microfill layer of composite. So they're going to be covered. So we're going to, have to see more when we place them so that they'll shine through that microfill composite. Also because they're not composite, they're just a lightly filled resin. So they're not going to be on the surface layer of our restoration. So use more than you think you need. And then we're going to use a brush to place our opacers. And these are brushes that we use for opacers. These are from Cosmodent. We use the number 1 brushes, which are the 2 brushes that are on the left side of the screen here. They've got a straight one and a bent one. And the kit that you buy comes with brush cleaner. So you can put the brush cleaner, dip that brush into the brush cleaner to clean off the resin on the tips of the brush. And then we just spray the handles down with a disinfectant like Cavicide and let them sit and dry before we wipe them and put them away. All right, next we're going to put our microfill composite. And I personally feel like a microfill gets a much higher surface shine than like a nano-filled composite. And a really high surface luster just makes a restoration look more natural. We've all seen those really flat, like matte composites in people's mouths, and they just give away the restoration. And I don't have any vested interest in the company, but I have used Cosmetic products for 30 years, and I'm really happy with them. I get free samples of others a lot. I just haven't found one that I feel like compares. And I have found them to be remarkably color stable over time. I just don't see them getting stain on the surface of the composite. Even in the most challenging areas, that gingival area where we have to battle against crevicular fluid or sometimes hemorrhaging. I feel like that's where the restorations generally start to stain or leak years down the road, but I would certainly say to work with whatever composite works best in your hands. And then regarding our surface texture, we obviously want to mimic the surface texture of the adjacent tooth when you're doing a class 4 composite like this. But if we're doing full bonding on multiple teeth, then we want to recreate the depressions on the labial surface between the lobes. So you remember from your dental anatomy class that the incisors are formed in 3 lobes, and there's often a depression between these lobes. And on some people, it's really pronounced. Other people, it's more subtle. You can follow the patient's general anatomy as a guide if they're happy with it. But it's usually also a lot easier to see if we look from this incisal or occlusal view. And there are tools that you can help use to form the depressions in your microfill composite while the composite's soft, or you can cut the depressions in with a diamond burr and then polish them with the composite polishing points. I prefer to use the tool to make the lobes in the microfill, because if you cut them in, you might cut into your microhybrid layer or into your opacers, and they're going to have a little bit of a different polishing property than your microfill.
I don't know how to respond.
And as we're looking at our polishing technique, you want a series of discs or cups that are going to give you a really high surface luster. So these are the Flexi discs by Cosmodent, and their sequence goes from the white disc, which is the most coarse, to the blue disc that you see here, and then the yellow, and then the pink. And the pink is impregnated with like a dental rouge, and it gives you a really high surface shine. And then finally, we use their enamelized polishing paste, which is your last step, and that's going to give you a really high gloss on the surface of your composite. And we put those on with this lavender flexi buff that you see here in the photo on the right. I also like the Softlex disc by 3M. Their series goes from like a dark rust color down to a yellow disc. And I really like their flexibility and their texture when we're doing composites. Any questions in the chat, please let me know. We're almost finished up with Sarah, but this is her final result. And then we've got her before and after in her full face photo. And overall, I think a really fabulous improvement for her. When I blow up my photos, there's always things that I feel like, oh, I would do that a little bit differently, you know, but this was a very happy patient and turned out, I think, very well for Sarah. So this is one of the cases that we'll be doing at our hands-on course at the Academy is the Class 4 composite. And then another case technique that we thought might be beneficial would be how to mask a single discolored tooth. And shortly after Javier and I started talking about this class, I saw these photos on social media. And this was, I saw these last summer while I was sitting at the beach on my family vacation. And this is our friend Jeff. And Jeff is the director of our marching band at our daughter's high school. And we love him and his family. So I decided, I know his wife very well. She's the head of the fine arts department, and I have a musical theater daughter. So I decided to reach out to Jeff's wife and see if she thought he might be interested in coming in and letting me take a look at this tooth to explore and see if he would be a good candidate for our course. And they were both so excited. And Jeff texted me immediately after his wife shared my email and said that he was practically crying because they had been holding off on treating this tooth for a while due to the cost. And he'd been to several dentists and they had recommended a porcelain crown or a porcelain veneer for him. But they have two young daughters in private school, and they just had not chosen to make the investment in the cosmetic procedure for him during this season of their life. So I'm going to play you a little bit of Jeff's preclinical interview. All right, Jeff, so tell me a little bit about the history of this tooth.
So I'm not exactly sure when it showed up, but I think it was sort of high school and college when it started to really make itself known.
And did you tell me your kids have a nickname for your tooth?
They do. They call it my golden tooth.
Okay.
My bling.
Yeah.
So
are you aware of your tooth on a day-to-day basis, or how does it affect you?
I mean, I've kind of grown accustomed, but at times it does make me self-conscious. I'm probably more inclined to give a closed mouth smile than I am a teeth smile.
Yeah.
And even had some whitening done before our wedding in consideration of wedding photos. And
excellent. So tell me what kind of treatment has been recommended to you in the past for this tooth?
I've had dentists recommend either a veneer or a 3/4 crown.
Okay. And then tell me, have there been any barriers for moving forward with treatment?
Typically, with the insurance coverage I've had, the barriers have been financial. It's something cosmetic is typically not covered as preventative maintenance. So that's been the number one barrier.
Well, thanks for telling us about it, and we look forward to helping take care of this tooth for you.
Thanks.
All right, so these are Jeff's full face photos, and you can see why his children call this his golden tooth. So like any good Dawson dentist, I got Jeff in for a complete exam. These are his full face photos. And you can see as you start to look at his photos that Jeff's got some chipping around these incisal edges here. And not very much tooth display at rest. And as we look closer, the alarms start to go off because you can see from these retracted photos that he has an end-to-end occlusion, and he's almost edge to edge on his front teeth. And the lower incisors are fitting right up into those chips on the upper incisors, just like a tongue and groove. And his lower incisal plane is uneven. He's got some rotated teeth. And in these one-to-one photos, you can really see how uneven the incisal edges are. So I'm thinking to myself that this single porcelain veneer or three-quarter crown that had been recommended to him several times would have maybe lasted until he got out into the parking lot. And his arch form looks pretty good, but you can see that number 23 is rotated about 15 to 20 degrees mesial in. So the treatment plan, the treatment sequencing that we landed on for Jeff was he was healthy. So we took him through our healthy hygiene program. We decided to start with some in-office whitening to see where we could get with his golden tooth. We treatment planned some Invisalign with home whitening gel in his aligners. And most of the time he would put the gel just on number 9, but he did some throughout his whole mouth. And then after his Invisalign, we're going to do new mounted models because it's a new case. We're going to do a wax up for those incisors that are chipped in occlusal equilibration, fix those chips on all the incisors, and then finally prep and bond tooth number 9. So this is Jeff's ClinCheck, and you can see with a little slenderizing of those lower anterior teeth that by the end, that we're giving him enough overbite and overjet to establish some anterior guidance and take the occlusion off of those maxillary incisal edges. Did it play? Let's see. There we go. Yeah, so this is going to be Jeff's finished position after Invisalign. And then these are his new mounted models. This is when we were already scanning and printing models, but we weren't doing our wax ups digitally yet. Now I'm doing most of my wax ups digitally, but this is his scanned and printed models after Invisalign, and we've done the equilibration on the models and an anterior wax up to restore those chipped incisal edges. And you can see that we've gotten him into a good class 1 canine relationship. So this is where Jeff left off after Invisalign and putting whitening gel in his aligners continually while he was going through Invisalign, primarily on number 9, but like I said, also occasionally on the other teeth, which is going to make masking this tooth significantly easier. In the photo on the right, we have done his equilibration already, and we've bonded the little smaller chips on the other 3 incisors. And then my colleague, Javier, who practices in Costa Rica, by the way, if I haven't mentioned that already, flew up from Costa Rica, and we did this case together so that we could film it for the resin class. So when we go through the class, you're going to see the video step by step of how we mask this single discolored tooth. But I'm going to take you through the sequence. Again, we're going to do our shade selection before we anesthetize the tooth. Then we're going to anesthetize and do our rubber dam isolation. We're going to make our depth cuts, same depth cut burrs, just like you use for porcelain veneers. For Jeff, we only had to do 0.3 millimeters of reduction since he had done so well with his whitening in his Invisalign aligners. We're going to etch and bond the whole tooth. Place our incisal microhybrid composite with the matrix, just like I showed you for the class 4 composite. Then we're going to place our opaquer. I'm going to show you the use of a pink opaquer that we're going to use to mask these discolored teeth. And we're going to place our body microfill composite on the labial surface. and then finish and polish and obviously check our occlusion. All right, so these are all just some photos that I've grabbed out of the video where we filmed Jeff's case. But remember, regarding shade selection, we're going to check before we anesthetize the patient. We're actually going to try all the layers that we think we're going to use on this tooth, including the opaquer, the hybrid composite, and the microfill composite. And we're going to cure them so that we're sure that we're going to get the right chroma and the right value to blend with our adjacent teeth. And then once we've selected our shade, we're going to anesthetize and place the rubber dam. And then we need to prep the tooth. So these are our depth cuts. We did, again, 0.3 millimeters of reduction for Jeff using these depth cutter burrs from Brasler. This is like a 0.25, but we did about 0.3 millimeters for him. And we reduced the incisal edge about 0.5 millimeter so we can have an incisal edge. The incisal edge, which is an occlusion and function, we're going to have built up in the hybrid composite. And you can see the depth cuts here, and you can take pencil and draw it right in the marks of those grooves, and then just prep back to those pencil marks until the pencil marks are gone once you have made your depth cuts. And this is our final preparation on Jeff's tooth. So you can see the discoloration a little more as we, are through. We're still in the enamel on Jeff, but, as we get a little deeper into the tooth, you can see that discoloration a little bit more. And we're going to use our matrix again from our wax up to place the microhybrid composite just where it forms the incisal edge. And we're going to replace what we prepared. And again, we want this to be in hybrid, microhybrid, because it's going to be in occlusion or in function. And this is also going to be the guide for how we build the contours of our labial surface, because we're going to leave the entire incisal edge on that matrix. And then we're just going to roll up a ball of composite in our microfill, and we're going to start at the gingival and work that ball of composite all the way down to the incisal edge that we've already established with our matrix. This is the pink opaquer that we place on the discolored tooth to block out that dark substructure of the tooth. And we're going to use those little brushes again from Cosmedent. We also show you some little brushes that you can buy at Michael's when you're in our resin course. So we're going to use the tiniest brush, the number 1 brush, to place our opaquers. And this is the full layer of pink opaquer in place on the tooth. And we're going to cure that pink opaquer. And we're going to talk a lot about complementary colors. The reason the pink opaquer works is because it's a complementary color on the color wheel. It's going to block out those, dark colors on our tooth. And the rule with tints and opaquers is that tints are going to lower the value of our tooth, and our opaquers are going to raise the value of our tooth. So that's going to help us make a dark tooth brighter when we place opaquers on the tooth. We used for him this pink opaquer from Cosmedent, which you can buy individually, just a tube of it. And this is fabulous. I wish I had included twice this month. I have used this pink opaquer on a crown preparation where we've been doing, say, 6 teeth. We've been doing porcelain on 6 teeth, and one of my centrals has a root canal and maybe an old post and is really dark. And we have cut back the labial surface of the crown prep a little bit, enough to place the pink opaquer and then a little bit of the microhybrid composite. Next time I'm going to include a couple pictures of that, but that's another great use for the pink opaquer. It just makes it a lot easier for your ceramist when you have these really dark teeth and you want to use Emax or something really nice and translucent like that. This is a great use for the pink opaquer as well. But you can buy it individually, or you can buy it in this whole kit that also has the tints in it and the brush cleaner and a couple of the brushes. And the tints also come in really handy with the provisionals because you can place tints like the honey yellow or the violet on the incisal edge of your provisionals and cure that to, mimic how much incisal translucency the patient might want in their final porcelain restorations. But and they've also got opaquers that come in the Vita shades. And we'll show you with the class 4 composite when we're doing that in the course. You can take, if you've got a really sharp fractured edge on your class 4 composite, and you're worried about that hybrid layer blending in with your microfill layer, you don't want to see that transition on your composite. You can take a little bit of your opaquer. I'm going to go to the next slide so I can draw on it and show you what I mean. You can take a little bit of that opaquer in like an S shape and run it across that junction between the broken part of your class 4 and the tooth, and just snake a little bit of that opaquer across that bevel, and it will help that color blend into the body of the tooth for your class 4 composite as well. But this is our thin layer of microfill composite that goes over the entire labial surface of our composite veneer that we're doing here. And one of the little tricks that we use to help you smoothly place the composite resin and press out any little air bubbles are these paint brushes. And these are just some little ones from Michael's that we picked up and show you how to use in the course, just to help, like we show here, smooth that layer of microfill composite down from your gingival margin down to your incisal edge and into those interproximal line angles. And then finally, we are going to use that same polishing sequence that we discussed with the class 4 composite and finish up with our polishing paste on these little felt FlexiBuff discs. And this is Jeff's after photo. And he is a very happy patient. I mean, I look at this and I can't even remember which tooth was discolored initially, which tooth was the golden tooth. So these are his full face after photos. We've got his beautiful smile photos. These are, you can see we've got a little bit more tooth display at rest. We've got a beautiful incisal edge that follows his lower lip line. Beautiful placement in the incisal third, tipping that incisal third of his centrals down toward his vermilion border on his lower lip. This is our beautiful occlusion, our class 1 occlusion for Jeff. Our lower incisal edges look way better. And his close-up photos. Really happy patient, happy dentists that worked on him. And we took Jeff from his golden tooth before he started to his final restorations. So this is a really fabulous technique that you can take back to use in your practice as soon as you come home from the course. And the last thing I want to talk about with you tonight is a little bit of injection molding. We go into a lot more of this in the course, but just one of the things, one of the tricks I wanted to show you for injection molding tonight is closing these dark triangles. How many of you have used this BioClear matrix before? You can like raise hands in the chat or let me know. I was just curious. I don't know if I can I pull it up? All right, so let me close that back out and I'll go back. So this, let me go back. There we go. Okay. So this has become a really useful tool for us, being able to close these dark triangles with these BioClear matrices. And this is the anterior kit, and it comes with this dark triangle gauge that you see here on the right. And this is an actual patient that I'm using it on in my practice. And you just stick this triangle gauge in and it tells you, this patient goes to the yellow mark. So we're going to use the yellow matrices on this patient to close her dark triangles on the lower anterior. But it comes with 4 different sizes, and the gauge helps you determine what size you need to, what color or what size you need to close your dark triangles. So another important factor when we're bonding to unprepped or unprepared teeth like this is that the biofilm has to be removed. So the biofilm is that organic film that we get on top of our teeth. It's difficult to see, and the phosphoric acid does not remove the biofilm. So we've got to remove it by some mechanical means. You can use something like this bioblaster that is shown here, the biofilm remover on the lower right part of the screen. That's basically an intraoral microabrasion unit or intraoral sandblaster. You can use a Prophy jet. That's what our hygienists remove the biofilm with every day. You can also use a diamond burr. But it's important, this disclosing solution that's up here on the upper right side of the screen, this is their brand, but you can use any disclosing solution that you've got in your hygiene department. And this, for example, is a picture after the teeth have been scaled and pumiced, and they look clean visually, but when you put the disclosing solution on, you can see that there's still a lot of biofilm on the tooth. So if you aren't going to be prepping teeth, it's very important that you use something, Prophy jet, diamond burr, biofilm blaster, or intraoral microetch or sandblaster to remove the biofilm. So this is Macy. And Macy was the first patient that came into our office right after we started using this technique. And Macy came in with a specific chief complaint that she wanted her triangles closed on the maxilla. And you can even see the triangle in her full face photo here. And afterward, you can see that Macy is so pleased. We used in hers the genial composite by GC, and it's made specifically for injection molding. And it works so well for these small triangles, especially in the gingival or the subgingival portion. For the larger ones, you may need to supplement a little bit of your favorite warmed composite in a compule and blend it over onto the labial surface. But for these subgingival areas, this genial works incredibly well. And it is what I will tell you about injection molding is that all flowable composites are not created equally. Genial is created for injection molding. It's like 63, 64% filled. So it's almost up there with a nanofill composite. And you should see these in the x-rays. They look beautiful. It looks like you've got porcelain all the way up to the gingival margin. Beautiful, seamless margins on these injection molded cases when you use that genial to go subgingivally. And this is her side-by-side comparison for Macy. And she was so happy. She came in, really, she was somebody that found us online and came in, just because of our reviews. And like the name of my practice is Aesthetic Dental Solutions. So I have a lot of people that find me and are referred by other patients or come in just for aesthetic procedures. And then they go back to their quote unquote, quote, general dentist. But Macy was so happy that she stayed and did all of her posterior restorative dentistry that I recommended for her with us, and she's become a hygiene patient. And so these services, these resin surfaces can really be practice builders for you. And patients may come in just for specialty care or for your reputation with aesthetic dentistry, but then they stay in your practice and they refer people that have similar interest and needs that they have. And this is Jacob. And I don't know, Jacob, are you on here tonight? I'll have to look. I didn't know if you were going to be on the webinar tonight, but Jacob is a dentist from upstate New York, and he had signed up for our resins course at the academy that we teach now. And he reached out to me by email before the course to ask about closing some of his triangles as well. And he had been to several colleagues in his area who all wanted him to do porcelain veneers. And he really just wanted to do additive bonding rather than prep the teeth and do veneers. And we were still early on in the process of using this technique, but he was glad to be one of our test cases. So this is his close-up photos, and you can see that his spaces are a little bit larger than Macy's, but still very manageable. And we couldn't talk Jacob into flying back in 2 weeks for his post-op photos. So these post-op photos are the same day. So you can see the evidence of our subgingival matrix and our polishing a little bit on the tissue, but Jacob was really pleased. And I would love for him to have longer central incisors or a little bit of smile redesign, but this was a great conservative way to address his chief concern. And these are his side-by-side comparisons. We just worked on the maxilla. We actually only worked on the 4 incisors. We bonded 8 sides. So we bonded the mesial and distal of the centrals and the laterals. When you're closing a triangle, you really need to bond on both sides of the triangle. But 8 different sides of teeth, it's good productivity for you as the dentist, and it can be done in a very reasonable amount of time. And for Jacob, we discussed adding to the mesial of the canines, but he was really satisfied with this result. So this is where we stopped. And he said it's given him a great deal more confidence in his smile. And if he didn't go back to his practice and start using this technique, especially after coming to the Resins course, then I would be shocked and disappointed. So look forward to hearing more about how his personal experience helped him in his own private practice. But great result for Jacob. And then I wanted to show you one other lower case. This is Cindy, and Cindy did Invisalign, and she had pre-op lower anterior crowding. Without a lot of IPR, you usually end up with these triangles in these moderate crowding cases. So with our shade selection, remember when we're doing direct bonding cases, you want to test out the composite shade that you think you want to use by taking a little bit of the composite and putting it in the same plane that you're going to be bonding, and then curing the composite. So here we just placed a couple different shades of composite right into those dark triangles and chose which shade that Cindy liked the best. And then this is where I showed you earlier, where we use the triangle gauge to measure the size of the space. So we just pop it right into the triangle. So here we're going to use the yellow matrices on either side of this triangle. And y'all do your resin cases with a rubber dam. Rubber dams are not just for dental school. We're going to show you this split dam technique in the course, but it's not rocket science. Just go a couple teeth distal to the teeth to your work area where you're going to work on each side, and place your clamps there. And if you keep the clamps super gingival, you don't even need anesthesia on those teeth. And then you're going to cut a slit between the teeth in your working space so that you don't get that rubber dam material stuck down in between the tooth and the matrix. And you should be able to get this on in 2 minutes or less. Your auxiliary really should be able to get this placed while you're doing a hygiene check. And so here we have got multiple matrices in place. I'm going to tell you when we finish this course, in hindsight, I only now do close one triangle at a time. When you've got 4 or 5 matrices on like this at the same time, it's just really hard to get in there and feel confident that you're getting your flowable down to where you want it to go. So I just close one triangle at a time now. It's this injection molding technique works so fast. You don't need to put 6 matrices in at one time. But this is her befores on the left-hand side and her afters on the right-hand side. And, you know, even on this upper photo where it didn't close at 100%, I mean, this is nothing that you would be able to see when she's speaking. And she is really a happy patient that you can't see these big triangles in her smile anymore. So before we wrap up, just a few takeaways. Injection molding, it's a really hot topic in dentistry now, but it's just one tool. Make it one tool in your tool belt. The things that we're going to really do with you in the hands-on course are the things that are more challenging, more difficult. These hand layered composites, the class 4 technique, the 6 composite veneers in a day, the bite opening cases where you're hand layering the composite, these kind of cases that you want to do if you want to get your accreditation in the American Academy of Cosmetic Dentistry. That's the kind of things that we're going to be teaching you. But these injection molding cases, they're one tool. Don't let it be your every tool. It's another inexpensive entry point for people to do some cosmetic dentistry. But decide how you are most comfortable removing the biofilm. Do you want to invest in one of these little biofilm blasters, or you're going to put them in an operatory where you've got a Profi jet so you can use that to remove the biofilm? Are you going to prep it away and use some disclosing solution to make sure that you've removed all the biofilm? I would invest in some of these BioClear matrices and some genial composite. They are really invaluable in these little aesthetic cases, like closing these dark triangles. Closing diastemas work very well with those matrices. Use rubber dam isolation. It should go on so quickly, y'all. I hate it when I see lecturers that are doing these composite cases with an Optrogate or retractors. Every study will show you that your moisture control is so much more superior if you use a rubber dam, and it's easy to get on. We'll show you how quickly you can get that isolation with the rubber dam. From my experience, I would say start by only working on one triangle at a time. Put 2 matrices in, one on your mesial, one on your distal. Close that one triangle, and then go to the next. Triangle. The other thing I would tell you that's a little bit different than how they might teach you if you took a BioClear course at the AACD, for example. They have you place the matrices first and try to etch and bond with the matrices in place. That is a hot mess, y'all. Just etch and bond those 2 teeth without the matrices in. You'll be able to get your brush in between the teeth. You'll be able to get your bonding agent in there much better. Then if you need to separate the teeth to get the matrix in, use one of those little clear white quick strips. I'm sorry, I should have taken a picture of that and posted it here in the slide, but you can take one of those little white quick strips. It's got an edge on it, kind of like a seri saw or whatever tool you want to use to separate those teeth. Then put your matrices in between the teeth and injection mold, squirt your genial composite in there, or your warmed composite. I would use the genial, the flowable, for the gingival portion at least. And if it's a big triangle, you might want to use some warmed composite in a compule just to blend that onto the labial surface. But you're going to etch and bond the whole tooth, just like we do for a class 4 composite. Because if you only etch and bond that interproximal, invariably you're going to get this flash of composite that comes across the labial surface that's going to go beyond the edge of your bonding agent, and that's going to be what picks up stain and becomes visible over time. So etch and bond the whole tooth, even though you're just closing that interproximal triangle. And you need to have some of those serrated quick strips, those white quick strips, or seri saws, and some finishing strips, interproximal finishing strips on hand to finish that gingival margin and the interproximal areas. And then my last thing is just do it, y'all. It is the injection molding is easy. It's not the harder, finer techniques that we're going to be teaching you in the hands-on course, where we're doing hand layered composite. This is something you can watch and do, and you've just got to find a staff member, or somebody, maybe you want to do your first couple cases at a little bit of a discount because it's your first time or two, but just go home and try it. It is really simple. It is going to be much quicker. It's going to end up much quicker than you think it is. So those are my little tips for our injection molding, and we're finishing up right on time. This is the name of our hands-on course that we're doing at the Academy now that Javier and I teach. It's called Mastering Composite Resin for Aesthetic Excellence. And we would love to see you there in May or in October. And Also want to show you a couple other things. We've got, if you have not done a Dawson course before, if you're just kind of dipping a toe into the water by coming to our webinar tonight, this is the first course that we recommend that you start with in our core curriculum. It's Occlusion and Smile Design. And the next one that we have is in May 17th and 18th in Nashville, Tennessee. And if you are not ready to do the in-person courses yet, you can learn virtually. We have this whole ticket to all of our live stream courses that you can go to throughout the year. And Javier and I will be doing one of the live stream courses, I think in June. We're going to be doing a 3-hour course on composite resins from front to back. And we're going to be talking about anterior and posterior resin techniques.